Top Med Talk. So hi, I'm Monty Mythen, Editor-in-Chief of Top Med Talk. Welcome to a very special edition. We're in Irvine in Southern California, celebrating 60 years of Edwards Life Sciences. Now, many of us will know Edwards Life Sciences in two broad guises. So the first time I was introduced to an Edwards Life Sciences product was a heart valve, which I'll come back to discuss with our guests in a second. And then in the other guise, it was advanced hemodynamic monitoring in the form of the Swan-Ganz catheter. So I've got three special guests for this first session: Andy Shaw, Rupert Pearse and Tim Miller. I'm going to start with Andy Shaw, ex-UK, via the United States of America, a few institutions there, now residing in Canada, previously been on Top Med Talk, discussing some fantastic trials earlier this year, the SALT-TD and the SMART trial about fluid management. So Andy, welcome.
Thank you.
So tell us about your new role, gone to Canada, interesting decision.
Yeah, so I'm the new department chair and zone clinical department head in Edmonton, Alberta. Edmonton zone, specifically. So we have 9 or 10 facilities, a little, depending on the day of the week, somewhere between 100 and 120 operating rooms, about 140 different anaesthetists, and we take care of everybody for anything. Alberta is one of Canada's provinces. It's a provincially arranged healthcare system, so it's a little different than the United States. For those that aren't familiar, the best way to describe it is it's a hybrid of the NHS and the American system.
Lessons for the NHS to learn from the system?
I think there's lessons that both systems can learn from each other, and in fact AHS, the Alberta Health Services leadership, are talking actively to the NHS leadership about things they can learn from a slightly larger system that's fundamentally set up from a care delivery perspective the same way.
And in your clinical work, are you still predominantly cardiothoracic anaesthesia and critical care? Or?
I do both. I'm in the operating room, the cardiac operating room, 2 days a week, and I pick up about 3 or 4 general days a month. And on top of that, I do 12 weeks a year in the cardiovascular ICU.
Now, I was reflecting with you earlier that my first exposure to an Edwards product was the Star Edwards valve as a junior doctor doing a cardiothoracic job, working with some of the giants of cardiothoracic surgery. We mentioned some names earlier, like Professor Sir Magdi Yacoub, Donald Ross, Marvin Sturridge, who you may not have known from the Middlesex Hospital, and they would tell us stories about the fact that when they started off in their surgical career, that they would put patients into ice baths until the heart stopped, and then the chest would be accessed and fingers would be put into the heart to try and split the mitral valve, for example.
Blind mitral valvotomy.
Yeah, so we've worked with the people who made that journey. And now if we look at the displays downstairs, the idea that people can have a new valve popped in, that's literally, almost literally.
Through a small hole in the groin.
Yeah. Are you doing that sort of work at your institution?
Yeah, we do. We do surgical and transcutaneous heart valves, both transapical and transfemoral, in all 4 positions. And we're not as big as a lot of American programs because there are number caps, but we put in, I think, a little over 75 TAVIs last year, and we'll do twice that number this year.
So for those people listening who aren't familiar with this, it is literally, very minimal access, long catheters that are placed via great vessels to change out the valve. Right,
so we've progressed, I guess, over the last 60 years from freezing someone in a bath to literally placing a valve with someone wide awake with minimal monitoring.
It's incredible, isn't it?
It is, and I think that's the way that things are going. The real game changer, I think, was the size of the access device, and that occurred between the 2nd and 3rd generation devices. And then the addition of the skirt around the valve itself, which effectively prevented or certainly minimized residual aortic regurgitation. That was a big game changer, and I think has allowed the indication to move away from ultra-high risk towards moderate risk and likely towards low risk. And that transition brings with it some interesting issues for those of us that take care of these people.
Like mine, would your first exposure in cardiothoracics to a valve have been a Star Edwards
It was,
valve?
The old ball and cage valve. I remember it well. I've actually seen one of those sewn in upside down of all things, but that was a while ago. We'll move on from that. But yeah, I remember those valves with fondness. Very occasionally you still see one, but typically they now feature in museum loops from an echo perspective.
And dramatic X-rays to look at.
Oh yeah, absolutely.
So we're here, reflecting on all of that. Very interesting. But we're here predominantly to discuss hemodynamic monitoring.
Right.
And for you in particular, I wanted to touch on the pulmonary artery catheter, sort of around the time that we were probably starting our careers. It was exciting to see a pulmonary artery catheter put in,
Right.
and then very rapidly it became a mainstream tool in critical care
Right.
and in major surgery. But it's had a rocky past. So about 20 years ago, there was some sort of observational studies that suggested there might be some bad news associated with it.
Right. So the pulmonary artery catheter has had a long and, I guess, a checkered past, in that you're right, in that originally it was the tool that people thought would bring, an end to complications certainly after high-risk surgery. And there was a lot of excitement about cardiac output guided management. And then those trials were unable to be reproduced, essentially. And then the Connors paper came in 96, which was really, I guess, the first trial that demonstrated that there may be a hazard. Maybe the benefit isn't as ubiquitous as people had thought before that.
And that was a large, predominantly US observational study, as I remember.
Right.
Yeah.
But the gist of that was, cool your jets, there may be a problem around the use of pulmonary artery catheters, which I think for those people like me at the time, I was a fellow at Harefield at the time, we were putting them in routinely for not just cardiac surgery, but for high-risk general surgery as well. And I think then there followed a series of studies that either supported the idea that there may be harm associated with pulmonary artery catheters, or that found it difficult to justify because the benefit was perhaps a little tenuous. And people started to worry about cost, and there built up a sort of an opinion in the community, certainly in the critical care community, that nobody needs to use pulmonary artery catheters because you can get the job done safer, better, with less invasive, less, quotes, dangerous devices. But there was an interesting piece of data that didn't support that, and that was that despite almost no commercial support, people continued to buy and use pulmonary artery catheters, which suggested to some of us, and this is why we did this study that we're about to talk about, that someone is seeing value in the device.
There are still lots manufactured.
Well, that's my point. When a product isn't supported at all, yet still continues to sell, it means that someone somewhere is deriving value from it. And so we surmised that the value proposition to the user was the clinician who continues to put pulmonary artery catheters in. And so we decided to look into that a little bit and try and study a population where the chance that the benefit would be significant would be findable, which was heart surgery.
If you look back to the Connors paper, at the time it came out, what was your instinct? Did you think it was the tool, this is an old adage, or did you think it was the fool on the end of the tool?
I've always thought that the best chance of a patient's best outcome is having a well-trained, thoughtful clinician who is able to integrate all of the data that he or she is given. And I think it's very difficult to blame a particular device, tool, drug for any particular bad outcome. So I don't think it's the specific device. I think it's the way that any device or tool is used.
Okay, I'm going to come back to the results of the study in a second, Andy, but I'm going to leave it hanging on the basis of the fact that I'm going to guess the next two guests don't know the results. They may do, but I'm going to leave that hanging for they might have reviewed it. Maybe that's why it took a while to...
Yes, if Pearse has seen this, no wonder we've been
this time.
So, Rupert Pearse, Professor Rupert Pearse from Bart's QMUL in London, been on Top Med Talk before, a number of occasions. Rupert, your early exposure to the pulmonary artery catheter, and I want to bring into that what people did with it. So this idea of supranormalisation in the critically ill compared to optimisation in elective major surgery.
Yeah, I guess the first time I saw a PA catheter was on my elective in Dublin as a medical student in a critically ill patient. I think since that time we saw, as I think Andrew describes, the highs and lows, not so much of the device, but our view of the device. We were falling in and out of love with it on a fairly regular basis.
But was that the device or what people were doing with the device?
I think it's not either. I think it was the politics and the perception of various factors, I think quite US-driven by charging to insert the device in patients who perhaps didn't need it in some cases was a big driver, and the New England Journal was a big driver of that because they published a lot of the less encouraging data. Meanwhile, you've got papers like the Connors paper, which wasn't a trial. It was actually a secondary analysis of an epidemiological study done for a completely different purpose, which everyone's sort of forgotten now. And I think we allowed the controversy around our beliefs to drive our interpretation of the research, to drive the research that we did, and that just kind of created a positive feedback loop in terms of losing all objectivity into how we used the device and what it did. And I think Andrew put it really, really nicely. You want a thoughtful, well-trained clinician making best use of all the data they've got. That will be...
So one of the iconic trials that was perceived as a negative result from the point of view of the PA catheter came out of your neck of the woods, where you work now, which was in critically ill patients, this pursuit of supernormal variables using high doses of dobutamine in particular to drive oxygen delivery to supernormal levels that had been observed in elective major surgical patients in this neck of the woods, in Greater California, by Bill Shoemaker in an earlier stage. Were you around at that stage? Did you practice that?
I was not at Bart's when that trial was done. I mean, that was a single-centre trial, and just a point on the terminology, that the terms of supranormal and so on were quite widely used across a lot of different trials, but this particular trial had a treatment algorithm that would, in some cases, in all, go up to very, very high doses of dobutamine and noradrenaline in a way that we would never do now, I think. But it's really important to be clear that was the intervention that people were pushing at the conferences at the time. That's what the KOLs were telling us to do. And David Watson, Charles Hines, Michelle Hayes, and so on.
It was an appropriate thing to pursue.
They tested what the experts were saying to do. And when that caused harm, which doesn't really surprise us now, when that was shown to cause harm, they kind of, the KOLs then attacked the messengers.
But what always struck me at the time, I remember it very, very well, living through the sort of dobutamine D.V. era, was the evidence came from elective major surgical patients, which is a completely different paradigm. It's a completely different setup. The idea that once you've got fully established sepsis and multiple organ failure, you could push the blood round more quickly and somehow solve the problem just seemed fundamentally flawed. How did that happen?
I think, and I've said this before, I think it's a tale of bad research.
Right.
And I think we all, myself included, to a greater or lesser extent, have a hand in that. And I think we really, really need to learn that lesson. But I think the key part of that story of bad research was that we were too keen to jump to the randomised trial before we did the proper mechanistic and translational research.
Yeah, take a slow, steady approach to these things. So Tim Miller, old friend of Top Med Talk, a regular on the programme from Duke University Medical Centre in North Carolina. Another Brit, though. We're spreading out through the world. They haven't caught us yet.
3 British voices here. Hello, Monty.
How are you, Tim?
Very well, thank you.
Great stuff. So, your first exposure to a pulmonary artery catheter? You may have avoided it. You may be young enough to
I am a little bit younger than my 2 colleagues.
Yeah.
So the pulmonary artery catheter was
I think
already...
that's in the eye of the beholder.
It was already... The use was already in decline by the time I really started practicing anaesthesia, which was around 2000. So it was already had its peak, I think, and was only being used really regularly for perhaps high-risk cardiac surgery rather than any other types of surgery. And we've also, by that stage, of course, had some of the less invasive cardiac output monitors start to appear on the market.
So as we talked about on Top Med Talk before, your department, your team that you lead at Duke are regular users of cardiac output monitors, so it's a part of your daily practice. Yeah. So you're into the idea of the fact that flow and oxygen delivery is important, but you are young enough to have embraced the less invasive versions of doing it.
Yeah, absolutely. We use goal-directed therapy for all of our enhanced recovery cases, so all of our major abdominal surgery, and we're really embracing the concept of goal-directed hemodynamic therapy, which I think we've largely had. We've had some studies which have looked at fluid optimization, we've had some studies that have looked at hemodynamic optimization, and really we should be combining the two. And
in your algorithms you address both volume, preload, afterload contractility. Is that the approach you have now?
Correct, yeah. We'll optimise fluid first. So I think you want to have a patient that's euvolemic, and if they're still hypotensive and the SVR is low, obviously that's a time to use a vasopressor. And if the cardiac index is low, that happens in a few patients perioperatively, then an inotrope would be the appropriate thing to use.
So, relatively recent, you've been exposed to HPI. We've got a round table with one of our guests, Thomas Sheeran, talking about HPI. Now, in talking about that hypotension predictor, using artificial intelligence, machine learning, one of the concerns is that people are going to start to go back to just treating blood pressure, which, from some of the lessons possibly from the pulmonary artery catheter is leaping ahead and jumping into the wrong place. How would you manage that in your institution? You haven't got your hands on it yet, have you?
We haven't, no. But I think that's very important. I think we're very clear with the messaging that fluid comes first.
Yeah.
And I think it's interesting that you can look at the same thing in two different ways. If we take the Pearse study, which was a study by Futier, which was in JAMA, looking at blood pressure control, essentially they fluid optimized first and then used a vasopressor, in this case norepinephrine, to optimize blood pressure. The Fedora study, which was labeled as a goal-directed hemodynamic therapy study, essentially did the same thing. They optimized fluid first and then used a vasopressor if needed. They're different. They're labelled one a blood pressure study, one a fluid study, but the algorithms were largely very similar.
So volume, flow, pressure.
Yes.
And Rupert, you're doing some of the biggest trials. Volume, flow, pressure still the key trilogy. It's not just the pressure, correct?
I think in essence they run concurrently, don't they? But yes.
So, Andy, the punchline. You looked at a large data set to understand pulmonary artery catheter use and outcomes. What did you find?
We did. That's exactly what we did. We went to the Cerner Health Facts data set. We found 6,844 patients undergoing major heart surgery, divided them into two groups, matched them using propensity scoring for risk of an adverse outcome, and we also controlled for severity of illness using acute physiology score. We looked at mortality, we looked at length of stay, and we looked at morbidity. And we didn't find a difference in mortality, which wasn't really surprising, but we did find a statistical difference in length of stay in the hospital. And patients who were managed with a pulmonary artery catheter stayed in the hospital on average a day less than those who were managed without a pulmonary artery catheter. We also found statistically significantly less cardiopulmonary morbidity in patients who were managed with a pulmonary artery catheter. But interestingly, there was an increase in the incidence of infectious morbidity in patients managed with a PA catheter, which is an interesting observation, and we have some thoughts about why that is. And I'll just say that it's almost certainly not because of line-related infection, because we actually measured that, and there was no difference between the two. It seemed to be driven by urinary tract infections, and we think, although we can't know because we don't have data about dwell time of either the catheter or the Foley catheter, but we think that patients who have a PA catheter still in are less likely to have their urinary catheter removed, and we think that probably bumped an increase in the incidence of UTIs.
And that's in Pearse, the paper in the Journal of Perioperative Medicine?
That's correct, yes. I just got the proofs yesterday, so that will be available very soon.
And the data's in the public domain because it was presented in abstract?
Yeah, I showed this at ISICEM in March 2017.
ISICEM is the Intensive Care Emergency Medicine Conference in Brussels.
That's right,
led by Professor Jean-Louis Vincent.
That's right.
And I think it was awarded a prize.
Yes, it was, which was nice. We think these data are, not to be flippant about it, but we think these data are important because they challenge a dogma that has grown up over the last, as you said, 10 to 20 years. And we know each other well. I like to challenge, dogma and stick in the mud thinking. I've done that a couple of times before. And I think that these data are important enough to prompt a larger dialogue about the place of different types of monitoring, not just necessarily pulmonary artery catheters, but how we think about and use different monitoring tools, different therapies. The most important thing, I think, is that we shouldn't be afraid to question things that we think we know, but actually we don't. I suspect both of these guys would agree with this, is that there's a lot of stuff we think we know, but if we actually ask ourselves to prove it, then we don't. And this is just an example of that.
And you can't judge from the data whether it was the fact that the patients were managed in a different style, whether they had goal-directed hemodynamic therapy.
No, we don't have that sort of granularity of data. In reality, that would require a prospective trial to get into that.
So, Rupert, any thoughts or reflections on that?
I think, I haven't had a chance to read the paper, but I think that it's another piece of the jigsaw, isn't it? It's another piece of the pattern. I think the point that I'm kind of hearing Andy make is don't chuck the PA catheter in the bin. I would agree with that. It still has a place.
And people have voted on that, as you said, Andy, because, it's persisted in being used in very, very many places, and therefore the people have voted with their hands, feet, pockets.
Dominated by cardiac, though, I suspect.
Yeah, well, this was just a cardiac surgical population. Now, interestingly, if you look at our two populations before the propensity score, they are very different. The patients who are managed with a PA catheter, on the whole, appear to be very much sicker.
Right.
And that underscores the importance of trying to match risk factors using, in a data set like this, a propensity technique.
Tim, we're going to wrap. Any reflections on that?
No, I look forward to reading that study. We largely use the PA catheter now for patients with right heart dysfunction, and I think as we're getting a sicker population, we're getting more and more patients with right heart.
More of them.
Exactly.
Yeah, I think we're seeing a renaissance, if anything, because the complex heart, the pulmonary hypertensive patient, the grown-up congenital heart patients, as they come through, there are reasons to increase the intensity of monitoring in some patients, but the flip side of that is as you alluded to, is the ability to measure flow and manage hemodynamics has been made much, much easier by the development of technology such as flow.
And we have treatment for pulmonary hypertension. We have, treatments that affect it. We have inhaled nitric oxide. We have inhaled, prostaglandins, inhaled milrinone. We didn't have those 20 years ago.
Yeah. So, in closing, thank you very much indeed, gentlemen. Thank you very much to Edwards Life Sciences for this opportunity, and congratulations on your 60th anniversary. So, Andy, I said earlier that I was going to give you a billboard, and on that billboard you can put your hemodynamic message to the young, hemodynamic managing message.
I think my message to the young, when did I not become one of the young, is that the right heart matters.
There we go. Rupert, what do you want on your billboard?
Pressure isn't flow.
Oh, excellent. Tim, you can take those two and say I can't trump it if you want. What do you want on your billboard?
No, I think that fluid and hemodynamic optimization can improve patient outcomes.
There we go. 3 billboards outside Irvine. Thank you very much indeed, folks. Bye. This is bye-bye from Top Med Talk. Look forward to talking to you again soon.
Yeah, thanks very much
for
the invitation, Monty.
Top Med Talk.